Our next speaker is Dr. Keith Lindor from now Arizona State University. He's the Executive Vice Provost and Dean, the College of Health Solutions, and he is a professor of medicine at ASU as well as the Mayo Clinic. And as you all know, he was formerly the Dean of Medicine at the Mayo Clinic for years, and he's our good friend. I think if this was a baseball team and I could be the manager, and if Eric Gershwin was leadoff batter, I'd want this guy for my cleanup hitter. Let me get some of the answered questions out of the way for you. Great. Thank you.
Well, it's very nice to be here. Thanks for that nice introduction, Buck. I think this is probably the 6th time I've been with this group. I remember being on a cruise boat in Biloxi, Mississippi, and one time here in Las Vegas, we had, I think, 3 chairs behind us over roughly in this area. People were coming up and we were drawing blood on stage for one of Dr. Gershwin's studies. Really put the pressure on us not to make those patients yelp. Well, it's really nice for me to have a chance to give you an update on where I think things are happening with PBC. Some of this will be a bit redundant to some of the things that you've already heard, and in those cases I'll try and move through that. Some of it will also be setting the stage for talks that you're going to be hearing tomorrow, and I'll mention that as we go as well. One of the things that we've seen is that there's been concern that PBC has been increasing over time. And so there's 3 slides that I'll show you about this. This data shows some of the figures that make it look as if PBC was increasing. So looking at a couple of sites in England, or 3 sites in England, there looked like there was this increase. So this is prevalence. Prevalence means how many cases there are in a region at one point in time. And then the next has to do with incidence. And these figures were from Rochester, Minnesota. Olmsted County, where the Mayo Clinic is located, is relatively unique in that all of the patients there's access to complete medical records for all of those patients. So very unlikely that a diagnosis of PBC would have escaped during this period. And what this shows is the incidence hadn't changed. So incidence are the number of new cases over a period of time. In PBC, it's over a year. And so this showed that the prevalence looked to be increasing while the incidence was stable. That usually means that the best explanation for that is that if there's a constant number of new cases, but there are more cases at any point in time, people with the disease are living longer. So that's how, with a stable incidence, you'd see a rising prevalence. But now these are newer data that show a different trend. So ursodeoxycholic acid, the Pupon study, was first published in The Lancet in 1987. And so what we see is that there's been this trend that's been fairly consistent from around the world of more cases, higher prevalence of this condition. Now, again, some of this may be related to the introduction of ursodiol and the extension of life, but I think also that this may mean that there simply are more cases that are occurring. One of the things that we've seen in another disease, celiac disease, gluten-sensitive enteropathy, is that there seems to be an increase in how common that disease is as well. And some people have likened a change in our food supply to become cleaner, fewer bacteria, and they think that that is somehow linked with an increase in autoimmune disease. A simple way of thinking about this is if our immune system is designed to get rid of bacteria that we ingest, if we take away the bacteria, we still have the immune system that's now looking for something to do. And one of the links has been, well, maybe we have this immune system that now turns on itself, hence this increase in autoimmune diseases. We don't know that that's the case. Other people are more expert about that, but that would be one explanation for this. Another explanation may be, and this is work that Eric Gershwin has been involved with, is that there may be an environmental influence, something new introduced to the environment that has been fairly broad spread and is increasing the number of cases of this disease. There are a lot of unanswered questions about this at this time, but I've heard Dr. Virling allude to diseases or conditions that were common enough to attract attention of the industry. We're starting to see some diseases becoming more common now. Dr. Virling also mentioned the difference between PBC and PSC. So on your left, this is looking at the number of transplants done per year in the United States. And there's just been a steady increase, which is good. There's been more organ availability, more patients who need transplant are coming to transplant. Remember, we still only transplant about 2/3 of the patients that need transplants. About 60% of patients that need a transplant get a transplant every year. So we're glad to see the numbers going. In PSC, compared to PBC, PBC is in the solid line. Over the course of time, while transplants are increasing, there's actually been a decline in the number of patients with PBC needing transplant, whereas in PSC, in the dashed line, we certainly haven't seen this type of impact. So this is good to see this. We're hoping that if this is continued with earlier treatment, that this drop in the need will improve even further. There are a number of things that can tell us who's not doing well, who has PBC, or can help predict who may not do well. And so this slide shows that those patients who have other markers of a heightened immune response have a variety of other autoantibodies. If they have those, either just anti-nuclear or anti-centromere or this poor protein called 210. If you have those compared to not having those, your likelihood of having problems from PBC are increased. So this, I think, just is that heightened immune response. Another correlate for this came from work that Raoul Poupon in Paris published, in which he looked at the liver biopsies and found that patients whose liver biopsy showed more intense inflammation had a more aggressive disease course. So this may provide some clues as to therapies. We may, in some point, break up people and say if you have either biopsy changes or if we don't do biopsies have these autoantibodies, we may want to try an additional therapy compared to just ursodiol. We haven't really done that. A number of years ago, we tried to do a study randomizing people to budesonide with or without urso based on their biopsy, but not very many patients had the finding, only about 20% did, and this was at a time when we were not doing very many biopsies. One of the other things that's been surprising is that if a person has fatigue with PBC, their outlook is somewhat worse. Why that is, we don't really know, but this shows that patients with who are non-survivors versus survivors had a higher fatigue impact score. And this shows when the fatigue impact score, some of you have probably taken, it's a series of questions that are scored that relate to quality of life, how much fatigue you have, what you're able to do during the course of a day. If your score is higher, over 40, your outcome is considerably worse than if you have a lower score or feel better. What this correlation is, we don't know, but I think it underscores the importance of fatigue in PBC. If we look at reasons why people become disabled who have PBC, fatigue is the most common. It makes up about 80% of the reasons for disability. So it's disruptive to the way a person lives, but it can also be disruptive to how long a person lives. So one of these areas that we wish we had targeted an effective therapy to go after. Tomorrow you're going to hear about FibroScan. This is that ultrasound technique that allows us to assess the stiffness of the liver. And this is a way to try and get a sense of how much scar tissue is in the liver. And one can see in this slide that in patients who have normal liver stiffness, their outcome in this French study over 7 years is as good as normal. maybe even better. Whereas those patients whose liver stiffness is high, they have more scar tissue in the liver, their outcome is not nearly as good. And so this looks like this can be a useful marker for assessing outlook in people as well who have PBC. Most of the time this technique had been used for chronic viral hepatitis, and we're only now more recently seeing this applied to PBC patients. And as Dr. Vierling pointed out, the test was approved by FDA in February, but it can't be reimbursed. So I think that until it gets reimbursed, it's going to be a little bit slower to catch on than we would like to see. I wanted to say a little bit about the liver biopsy. Dr. Vierling talked about that. This is a liver biopsy showing what we call a florid duct lesion. Florid meaning that there's just a lot of inflammation. The dark blue little circles are lymphocytes. That's the inflammation that we see. This finding, a florid duct lesion, is diagnostic of PBC. But it's only found in about 8% of biopsies of patients with PBC. So sometimes I will see patients who have a liver biopsy that is compatible with PBC, the term Dr. Vierling used, but some pathologists are reluctant to make the diagnosis unless they see this florid duct lesion. If that's the case, that pathologist by definition will miss at least 92% of the cases. If they're perfect in identifying the florid duct lesion, but require that for a diagnosis, they will miss over 90% of the cases. And hence the importance of what Dr. Vierling talked about, the accepting what's compatible with the other clinical setting, because it's important that the diagnosis be made, and it would be inappropriate to be such a purist to only make the diagnosis when this characteristic but rare finding was present. I know sometimes people they'll come and they're concerned that they don't have the characteristic feature, and do they really have the disease? And I think and sometimes it's because that they have that question because their providers don't necessarily have a lot of experience and are reluctant to make the diagnosis without this particular finding. We've really moved away from doing liver biopsies. We find that if a person is AMA positive and they have an elevated alkaline phosphatase, their transaminases are not that high, that they essentially have PBC. In a study we did when we looked at patients in this setting, made a diagnosis before a biopsy and then did a biopsy, we changed our mind in about two out of 100 cases. And those two were to add fatty liver to the PBC. So it's if a patient's values meet these criteria, they have PBC. A biopsy will not be necessary to confirm that. Now, one of the things that practice guidelines will tell us is that patients who have cirrhosis should have a variety of things done. Well, if we're not doing a liver biopsy, how do we know who has cirrhosis? And so an easy way is to look at the platelet count. If the platelet count is low, and this is due to the spleen being large, and as Dr. Vierling explained, with portal hypertension, scarring of the liver, blood from the spleen can't get through. The spleen enlarges, the enlarged spleen traps platelets, and we can measure the platelet count. That's a very easy indicator of who is likely to need screening with endoscopy for varices. The other thing we can do is look at the Mayo risk score. It's a little more complicated, but in either case, if the risk score is high or the platelet count is low, then that's a patient that we worry about being prone to developing portal hypertension and would be eligible for screening. Why is this important? Varices, these dilated veins that can occur in the esophagus when blood can't get through the liver, have a risk of bleeding, and if they bleed, the risk of dying is about 20% from a variceal bleed. So they have a high risk. bleeding can be prevented either with use of a beta blocker or with band ligation. And so identifying patients who are at risk and preemptively dealing with those before they have the bleed it has improved the life of a number of patients with portal hypertension. I wanted to talk just a little bit about, make a few points about ursodiol. This is a slide that we showed to get FDA approval for this. Now, it seems like yesterday, but it was 1998 when the FDA approved it. So this showed that when urso is compared to placebo, and then 2 of the 3 studies switched over from placebo to ursodiol after 2 years, that there is a substantial improvement in survival free of transplant. Now, a couple of other things just to say. When we look at treated versus untreated patients, you can see that treated patients do considerably better than untreated patients who would be defined by Mayo Risk Model survival. The other thing, when we looked at a French control group, normal patients, or normal people, the treated patients were slightly lower. When this study was presented, we did an analysis afterwards because we were asked. And one of the things we wanted to ask, the question we asked, were there subgroups that seemed to do better? And one of the subgroups that did better during this 4 years was those patients with cirrhosis. And by that, we could show an improved survival free of transplant within 4 years with ursodiol therapy, and it turned out to be only in patients with cirrhosis. So patients with earlier stage disease, during the 4 years of this study, we could not show a survival benefit. So there's some purists, or misguided purists, who said, I believe, who said, the data only shows that survival is improved for patients with cirrhosis. So you should wait until patients become cirrhotic before you initiate treatment, because that's what the data showed. So fortunately, in France, the group there addressed this question. So they looked. If they looked at patients who had cirrhosis, and again, this is now looking at all treated patients, it's this same data set, treated patients compared to controls or untreated, what they showed is that in the treated patients who had cirrhosis, their outcome is shown on the right, substantially worse than the French controls. But when therapy was initiated early, before a patient became cirrhotic, over this period of follow-up, which was about 8 years, these patients had a life expectancy no different than the French control, the healthy people. And so really, that misguided advice to wait until people develop cirrhosis and then start treatment would have confined people with PBC to this curve. So that's some of the complexities in interpreting these data. The time frame becomes important. If we only looked over that 4-year period, the only people who met entry criteria who would die or need transplant during that period had cirrhosis at the beginning. But that would have that strict interpretation, I think, would have been tragic. So some of the things that we've been interested in is what happens when people don't respond to ursodiol. We know that after 5 years of therapy, about 1/3 of patients will have totally normal liver tests, but that's only 1/3. You'll hear more. We've talked a little bit about alkaline phosphatase. And this has been important for us in trying to identify drugs that might be used in combination with ursodiol. We wrote a paper in 1999 and just sort of arbitrarily picked twice normal. This is a more recent paper looking at various cutoffs of alkaline phosphatase. So what this did is looked at patients with PBC on ursodiol for at least a year and then asked, over the ensuing 2 years, what's the likelihood of developing serious complications from the liver disease? And this is based on various cutoffs of alkaline phosphatase. So this shows, now, one, we wish the percentage of patients reaching endpoints was 0, but it's about 15%. This was developing cirrhosis or varices or other problems. But below 2, which is the yellow one, the risk is no different. So if your tests are normal, 1.5, we use 1.5, 1.67, or the Canadian one, and 2. If it gets over 2, then the risk becomes substantially higher. So there's a Intercept has funded this PBC supergroup. Data from many thousands of patients have been aggregated, and they've gone through and re-looked at the number. And a recent publication would suggest that twice normal is a reasonable number to use. So it kind of goes between 1.67 and twice normal. But in this general ballpark, if the values are at that range, patients do well. If they get higher, then the risk of problems seems to accumulate. In the initial study, we looked at twice normal, 3 times normal, 5 times normal. And if patients' alkaline phosphatases, although there weren't very many, were 5 times normal, the risk of complications was about 70%. So the alkaline phosphatase, we believe, is a very helpful marker in trying to assess risk while you're on URSO therapy. So our goal is usually less than 2-fold, maybe 1.67. Now, there are a variety of other drugs that have been tested for patients with PBC. Dr. Vierling mentioned the bezafibrate, fenofibrate, and I'll show you some data from fenofibrate. Bezafibrate is not available in the U.S. Have any of you looked up fenofibrate, looked at the PDR? The PDR will say contraindicated in patients with primary biliary cirrhosis. So it was pretty well tolerated in our study, and I think this came out later, but that's been an issue for people to go on it. Most prescribers are a little reluctant to go against a black box warning on the prescriber's information that says contraindicated. Bezafibrate has been used in Japan. As luck would have it, this morning I got up early and I had to review a paper, and the paper had to do with long-term use of bezafibrate in a Japanese population. And it was a little bit disconcerting in that they had follow-up in about 25 patients up to 8 years. And patients on bezafibrate plus URSO compared to URSO alone developed kidney problems late. Several patients had to be taken off the medicine, and they had 3 deaths in the bezafibrate group and none in the URSO alone group. So these occurred late, and so I think that these data not yet published, I think give us a little bit of warning about the bezafibrate. I don't know that we have similar data for fenofibrate used in the U.S., but again, I think it's important that we have data to demonstrate both efficacy and safety. The data from studies that are 1 and 2 years long didn't show any of these later complications, just showed the improvement in liver tests. And at 8 years in the bezafibrate group, they did have the improvement in liver tests, so those were sustained. Now, the numbers were small enough that we have to be skeptical, but I do think that it's going to be important that we have more information on bezafibrate and fenofibrate before making very bold recommendations about their use in patients such as you. I'll talk a little bit about milk thistle, Silymarin. A lot of people with liver disease are interested in certain states. 30% of the patients with hepatitis C are on milk thistle. States just a little bit further west of us, California. Very, very popular. It's been tried in PBC. The data are not very compelling. I'll show you those in a minute. I'll show you data from B-cell antibodies, the Rituximab. One of the challenges with that is it requires multiple infusions, and the infusions are about $10,000 each, so a very expensive therapy. I'll show you the data for that. And then just show you a few slides on the FXR agonist. Lee McConnell is here from Intercept. She has a whole talk tomorrow about this and knows a lot more about the data than I will. So just an introduction to that topic. So these are the data from the study Cynthia Levy published looking at fenofibrate in the U.S. You can see a prompt improvement in alkaline phosphatase values. The normal was about 100, so this was bringing the patients down below the twice normal, and then after a year, after 48 months, the rebound that occurred. This is a study that we did in conjunction with her, so we knew some of the side effects. A number of patients had to be withdrawn because of muscle cramps or aches, one for potassium problems. So this is we would like to see this type of study expanded, more data, longer period of follow-up to help demonstrate both effectiveness and safety. But it does look promising. But again, remember what I just told you about the closely related bezafibrate and some of the late problems that occurred. In another study, we looked at milk thistle Silymarin. We had a supply from a company in Germany called Matus. The drug was called Legalon. That's been one of the challenges with a lot of the herbal preparations, is an inconsistent supply. They're not, the suppliers aren't regulated like they are for drugs with the FDA, and so sometimes we get a supply of drugs might be gotten, and either the strength of the product is variable, and even worse, sometimes the product is contaminated with something that has unexpected and bad side effects. So this was using a consistent product, came from a well-respected German manufacturer, but didn't really do anything. You can see all along, looking at baseline versus end of treatment, this was a year-long study, how little change that we saw. So unimpressive findings with Silymarin or milk thistle. These are the data from the Rituximab study. So if patients' tests got worse, the lines went above the middle line horizontally. If they got better, it dropped out. So you can see that there was improvement in more people on the Rituximab than there was worsening of tests. It wasn't universal. And I think it would be great to have a product that wasn't as expensive. The Rituximab is given as an infusion, that's why it's so expensive. But this, I think, helps open the door to B-cell specific therapy. So Rituximab gets rid of B cells in the blood temporarily. So the discussion, I'm sure Dr. Gershwin talked about the antimitochondrial antibody that's produced by B cells and the role of B cells. And so this is a therapy targeted at B cells and shows that it has some benefit, at least in lowering the liver enzymes. So our hope is that there will be orally available anti-B cell therapies that we could get a similar effect without the expense and inconvenience. And then these are a few slides about obeticholic acid. Initially, we found really fairly dramatic improvement in alkaline phosphatase, irregardless of the dose. 10 was as good as 50. The itching and side effects were more with a higher dose, and so this has been, this initial study served as a very important basis for designing future studies in which lower doses are being used to try to maintain the efficacy, the effectiveness. Why would you pick 50 when you saw this many more side effects and that much more itching, when the results were no better than 10. So this was sort of a good example of the nature of these studies, where results from one study can help us inform us and better design the next study. So in this case, 3 different doses were used. We see benefit biochemically, but we also see a side effect profile that looks dose dependent. So that caused Intercept to look at how they might design the next study, and Lee will talk to you more about the doses that are used, but this is just a sort of a harbinger of what you'll hear tomorrow. And then this is looking just kind of the whole concept, like I showed you in the Fenofibrate study, is that we treated for a period of time and then the drug was stopped and we start to see the rebound. So in most of these cases, when we're treating patients with PBC, we're not looking for a cure so much as a way to control it. And sometimes stopping the drug and seeing the changes go up tells us that we don't have the cure. Some of the other things that we know is that if we double the dose of ursodiol, that it wasn't helpful. We did this before we had the results of the high-dose urso trial in PSC. Are you familiar with that? If not, we used a dose that's about twice. So the dose in PBC, the approved dose, is 13 to 15 milligrams per kilogram per day. In PSC, we had used that dose and not seen much benefit. Higher doses look promising. We used a double dose, and to our chagrin, about twice as many people receiving the double dose had major problems, died, developed varices, needed transplant, as those getting the placebo. So doubling the dose, we don't know that it's not harmful in PBC, but we know it doesn't help. And based on the PSC data, we think that that high dose has some direct harmful effects on the liver. The other thing it did, this is yet a little bit more of an aside, was that it increased the risk of colon cancer. So patients with PSC typically have ulcerative colitis, about 70% in the US do. The risk of colon cancer is increased if a person has ulcerative colitis. PSC increases the risk of colon cancer compared to ulcerative colitis in that group about 5-fold. So there's been lots of interest in using ursodiol as a chemopreventive to prevent colon cancer. And if the dose is used in PBC, there's some evidence that that occurs. But in the high dose, the double dose, it looked like it actually increased the risk of developing colonic polyps and cancers. So again, I think it's important that we with your cooperation, are able to address these questions rather than just trying something, because the last thing we want to do is try something and then have it be harmful. And it's oftentimes only in the context of these careful clinical trials can we start making these observations and answering these kinds of questions. I wanted to move away from specific therapy and talk about a few specific complications or problems. So a number of years ago, there was some data that suggested that patients with PBC had a very high risk of developing liver cancer. And some of you may have been involved in surveillance programs in which we asked you to come back every year for an annual ultrasound to look for cancer because the risk seemed so high. But then at one point we just said, we're not really seeing this many cancers. They were talking about 2 to 3% per year in patients with more advanced PBC. So we looked we had 2,500 patients that we had seen at Mayo over about a 25-year period, and we found just 18 cancers. So that's a long ways away from 1 or 2% per year. So this is a really small number, but the other thing that this told us was that there were some things that increased the risk. So we know cancers are more common in people who are older. Men with PBC men in general are prone to liver cancers. We don't quite know why that is, but certainly we saw that, in PBC as well, where being a male increased your risk about 5.5 times for getting cancer compared to a woman with PBC. Transfusion seemed to be the case, male risk score. So this really allowed us to step back and say, the risk of cancer is really quite low. We don't need to screen everybody every year. Let's focus on men, older people, patients with advanced disease. And that's made a difference. Now, one of the other things before people embark on a surveillance program is to ask whether it does any good or not. So these are data that show what happened to patients who were in a surveillance program or not. So what this looks at is survival with liver cell cancer in the setting of PBC. So if patients came to attention because of symptoms, their outlook is shown in the dark line at the bottom. Whereas those patients who were in a surveillance program and had early cancers found, we could oftentimes keep them going for quite a long period of time. I remember one male cardiologist who probably had 2 2 resections and seven liver tumor ablations over a 12-year period. So substantially better than the short duration. One of the things, just to point out, I hate to show you as patients these, but a liver cancer in a patient with PBC is bad. One of the things we use is median survival. And if you look at this, the black curve, if you look at where the 0.5, that means 50%, look at where that is. That's at about 6 months. So that means the average patient will live 6 months if they develop a liver cell cancer. Now look at the surveillance population and look where that's moved out to, where that 50% line comes out to. That's moved out to about 3 years now. So by getting the surveillance, if you're at risk, your likelihood, if you develop a cancer, is much better of surviving if it's caught early and can be managed. So that's one thing to remember. We don't like to talk about it, but if you are one of the at-risk patients, get yourself in a surveillance program. Every 6 to 12 months, all it is an ultrasound. I mentioned earlier that the men who develop the cancers tend to fare poor. This is a different study from Scandinavia, just reiterating the poor outlook for males. And then just a few words about some of these other complications of liver disease that can occur more commonly in patients with cholestasis. For the bone disease, which is increased more likely in patients with PBC than normals or other liver diseases, primarily because average age of onset is 53, 90% of patients are women. So it's really, this is a disease that affects people when they're already going to be prone to osteoporosis that occurs postmenopausally. Calcium is important. Vitamin D, if there's a deficiency, should be added. We don't use estrogens now, although they could be used safely. We don't really use those for osteoporosis prevention. The variety of bisphosphonates, and I'll show you some of the data about those. This is looking at the risk of osteoporosis. So osteoporosis is the more severe form of bone loss. In comparing different ages of people with PBC in the dark lines versus in the control. So you can see that the risk of osteoporosis increases with age, as we know it does, but at every age it's more common in PBC patients. So this is important to be screened for. Bone mineral density, a simple X-ray test, just takes 5 minutes to do, can tell you if you're at risk. If you're not at risk, repeating it every 3 to 4 years would probably be reasonable. In this study, we used one of the early oral bisphosphonates, alendronate or Fosamax, and compared that to placebo. And we saw an improvement in bone density in this case, I think this was in the spine. Now, one of the other things that has happened is there's been new drugs that have been formed. So ababronate once a month was compared to alendronate once a week, and the results are pretty comparable. So there hasn't been a study yet with the zoledronic acid, the one that can be used once a year. The ababronate is used once a month. But the good thing is that there are therapies that can be tried for patients with osteoporosis. Before, we were really pretty stuck. Calcitonin didn't help, and we were left trying estrogens and calcium. I want to talk a little bit about itching. I mentioned earlier the importance of fatigue, but itching is the other really common symptom. About 30% of patients will complain of having itching at some point, maybe even higher on your websites. Ursodiol at the dose that we use, 12 to 15 milligrams, doesn't really reliably help. Cholestyramine, most people will have tried that for itching. It's kind of unpleasant to take. It's gritty. Can be taken 3 to 4 times a day. The nice thing about it is that the dose can be reduced if the itching is controlled. There's another product, another resin called Welchol, which doesn't work as well as cholestyramine. So that was studied, and it doesn't really have the benefit. Naltrexone can be used. Many of us will use rifampin. Rifampin has the advantage of working quickly. It's a pill once or twice a day. It'll turn tears orange, urine orange, and about 15% of people taking rifampin will have an increase in their liver enzymes. That goes away when the drug is stopped, but it's important if you use rifampin to have the liver enzymes checked. We usually do it at 2, 4, and 6 weeks after starting. Naltrexone can do the same thing. Lumina is here. They're one of the sponsors. They have an ileal bile acid transport uptake inhibitor. So what this means is it's a medicine that when it's administered, it prevents bile acids from being taken up again in the distal part of in the far part of the small intestine. And so it starts to, then those bile acids get excreted and it starts to reduce the bile acid pool. The concept is that there may be itching substances in that pool, and so it keeps those from being recycled and they get excreted. So they have a study, a randomized trial that they're enrolling patients in now. Hopefully some of you are part of that. And that's really, I think, a new and novel approach to managing itching. So I was talking to Kara earlier, and it sounds like about 42 out of 60 some patients have been enrolled. So we're hoping that we'll have results from that study in the next several months. Another pathway that's recently been discovered, for which we don't have therapies at this point, is something called lysophosphatidic acid, or autotaxin. I won't go into a lot of detail about this. These are a couple of compounds that seem to perhaps be in the bile. This may be the itch. It's been difficult to say that itching is due to bile acids, but we've always felt that there's something in bile that might be related to it. This looks like a good candidate, this lysophosphatidic acid. And so it's our hope that with some of the pharmacology work that's being done, we'll be able to either inhibit the conversion of the lysophosphatidylcholine into the acid, or be able to prevent the formation of this in the first place. So hopefully within the next 2 or 3 years, we'll be at a point where this pathway might lead to therapy. I just looked over here, and someone with a back scratcher was scratching and passing it to their neighbor. So pruritus is alive and well in the world of PBC, and we really do need new therapies for it. So we're hoping that the Lumina product might be helpful. We're also hoping that there may be something that comes from this pathway. And then a few things about hypercholesterolemia. Dr. Virling mentioned this, the issue of lipids. I wanted to, one of these things, some lipid-lowering agents cause rise. This was a study with clofibrate. Clofibrate is linked to fenofibrate, bezafibrate. It's one of the fibrates. In old studies, when we used clofibrate, cholesterol actually went up. One of the things that I think has been such a change for me in the years I've been involved in this practice is the effect of ursodiol on pulling cholesterol out of the skin. We used to early on see, before ursodiol was available, people with these tendinous xanthomas. I remember a person, a pipe fitter, who couldn't close his hands just because he had so much cholesterol deposit here. And then with ursodiol, it disappeared. It's very common to see people who had the heavy cholesterol deposits underneath their eyelids. That's almost a physical finding that's disappeared, which has been great. So we know that cholesterol can be mobilized with ursodiol. We tried to do a study years ago looking at ursodiol as a treatment for coronary artery disease without PBC, but in the patients without cholestasis, it didn't have much effect on cholesterol. We keep saying that there's really no evidence that the high cholesterol levels cause problems, but this is a slide that sort of sticks in the back of my mind. So if we look at what you'll see observed expected, and then a statistic. And so what this says is that there's no statistically significant difference between the observed and expected. But if we look numerically, coronary events were about double what would have been expected in PBC patients. And this, when the number in brackets is, if it's instead of 2.19, if it said 1.01, then we would say this is a significant difference. So one of the issues with statistical studies is we're sometimes limited by the number of patients that we have. So I have an open mind based on this about the importance of high lipids in patients with PBC. So the similar findings we're seeing with stroke. They weren't as dramatic, but if we just looked at the raw numbers, this would be saying the risk of having a heart attack is twice as high as would have been expected. So I think that we can't be too oblivious to these numbers, and I think we simply just need a bigger study. I'm hoping that this big group that we put together, the PBC super users, might be able to help us address some of these issues, because literally there's thousands of patients there, and we should be able to know if stroke or heart attacks are available. Lee's in the back. I hope you're taking notes, and maybe this would be a terrific study for that group to look at. So just before I take questions, the initial data told us that we're seeing more PBC. It's unclear whether that's better recognized, people are living longer, or there's something that's happened in the environment to increase the number of cases. This is a slowly progressive disease unless a cancer intervenes. There are a number of things that we can do to look at the risks. We can look at who has a hyperimmune state. We can look at fatigue. We can look at fibroscan to see the amount of fibrosis. Ursodeoxycholic acid is the treatment. It's, I think, really withstood the test of time. The challenge with it is that's the only drug that we currently have. We need more drugs, either drugs to be used instead of ursodiol for incomplete responders, or drugs to be added to ursodiol, and hence some of our excitement with some of the new studies that are emerging. And then I talked about some of the specific complications, particularly the risk of developing liver cancer if you're at risk. The options that we have for treating the bone disease, so the importance of screening and getting treated for that. Some of the things that are on the horizon for itching, and then the somewhat open question about the risk of cardiovascular disease. What we're seeing also is, because ursodiol is causing people to live longer, we're going to have more and more experience with people at older ages who are at risk of cardiovascular disease itself. So these people will be living longer and have more chance to develop those. So the importance, I think, of us trying to weigh in on this. So appreciate your attention and the chance to come back. As Buck is coming up here, his two stories. I was a much better baseball player, softball player than golfer. I empathize with his golfer in the woods. So one question has to do with the difference between fibroscan and MRE. So MRE is magnetic resonance elastography. It requires an MR scan. MR scans nominally are about $4,000. So sometimes you can get them discounted. The MRE has to be done with an MR right now, and so it's kind of a freebie added to your $4,000 check. The elastography is an office-based procedure. You'll hear more tomorrow what it costs. I don't think it's a particularly expensive machine. It's pretty simple, and so it can be done in an office. In Europe, it's used commonly, and they're handy little machines to have. I suspect that in the future, those will become pretty much part of almost annual visits for people with PBC. The dose, fenofibrate doses that we use, I think, was 140 3 times a day, or about 420 milligrams. The bezafibrate study that I told you about was about 400 milligrams of bezafibrate. Someone asked a very good question about Alzheimer's and dementia. And the relationship between hyperlipidemia, statin therapy. I'm not aware of any data specific to this in patients with PBC, but I think some of you are aware that there's been questions raised about the overall value of statin therapy. So I don't know. To the best of my knowledge, there's no increased risk of dementia or Alzheimer's in patients with PBC, but I don't know that that study has ever been done to say so. This related to the relationship between fatigue and prognosis. And the person asked, could this be due to not being able to exercise, eat right, work, etc., therefore lifestyle problems with fatigue being a primary impact? I don't know. We don't really know which comes first. Do people have fatigue and because of that don't do all of these things they know they should? Or are they like athletes or other people who don't do these things they should, become deconditioned and have fatigue? I think that we don't have an answer to that question yet. We know that in general people who are deconditioned or out of shape have a lowered lifespan as well. So we'll and someone else asked, does the same thing occur when the alkaline phosphatase is improved? That is, does fatigue relate? If your alkaline phosphatase is better, does the presence of fatigue cause problems? We don't know the answer to that either. Another question for the supergroup to try and address. The question had to do with prioritization on the transplant list, and so it's not specific for PBC. Patients with liver cancers tend to receive extra MELD points, so they receive prioritization. And yes, liver transplantation for the right patients can be curative for liver cancer. About somewhere around 30 to 40% of transplants now are being done for liver cancer. What happens, well, and the reason that they do that is patients with liver cancer, you saw the numbers, median survival 6 months. So this is a group of patients that can't afford to wait the 1 to 2 to sometimes 3 years for a transplant. So they've been prioritized. Okay. This is a technology I don't know about. It writes, color MRI technology has been very successful in detailed imaging in PSC. Any plans to do it in PBC? I don't know this technology. There's something called PET scanning, which has been used in PSC. It's looking at positron emission tomography combined with CT scanning. And initially it looked like it was going to be a very important way of trying to identify cancers in PSC, but it's turned out not to be helpful. I'm not sure if Robert wrote this question because color is spelled C-O-L-O-U-R. So if Robert did ask this, maybe he can answer it. Oh, well, it could be a Canadian then, too. All right. So thank you. I'll be around. I think there's a friends and family session later, so thank you.
Once again, thank you so much for all of your patience in answering all these questions, as well as a very entertaining and informative speech.
Thanks, Mike.
Appreciate it.